G'day, I'm Dr. Paul Mason, sports medicine physician and physiotherapist.
And I am Dr. Doron Sher, orthopaedic surgeon.
And today we're going to teach you how to examine the knee.
This is based on a combined experience of 40 years between us.
39 of those are yours, right?
I'm the senior member of this team.
Let's get into it.
An efficient knee examination should have a logical sequence that doesn't require the patient to be constantly moving around. The bulk of the examination can be performed with the following sequence. Begin in standing and then transition the patient to sitting. From here they can easily transfer first to supine and then to prone. By avoiding unnecessary position changes, the overall efficiency of examination is improved. In fact, once practiced, a complete knee examination can be completed in 5 minutes. Also remember that the knee should not be examined in isolation. It exists within a kinematic chain, and impaired function at either the hip or ankle joint can impact upon the knee. Furthermore, pain experienced about the knee may be referred from another site, most commonly the lumbar spine or hip, and these regions should be examined where appropriate. The knee examination commences with inspection in standing. Both knees should be exposed until at least the mid-thigh to facilitate comparison between sides. Begin by inspecting from the front. The first thing to take note of is alignment. As a rule of thumb, the knee should fall within a line between the anterior superior iliac spine and the middle of the ankle joint. The most common malalignment you'll observe is genu varis, or bow legs, usually caused by disproportionate loss of articular cartilage in the medial joint compartment. Understand that while some scars can be obvious, many are not, and so they're often best observed in supine. Muscle wasting or atrophy is best appreciated by asking the subject to push their knees back and tense their quads. If you do observe asymmetry, objective measurement can be made with a tape measure either in standing or supine later on in the examination. Be mindful that not all wasting is secondary to disuse. Quads wasting may also be associated with pathology of the L3 or L4 nerve roots, which can also cause knee pain. After anterior inspection, inspect laterally, again asking the patient to push their knees back. This will make any fixed flexion deformity where the knee doesn't fully straighten quite obvious. A screening assessment of the ankles can be performed by asking the patient to first calf raise and then quarter squat with the heels on the ground. This will allow you to observe for any significant restriction in ankle range of motion. We then inspect posteriorly. The most common anomaly you'll observe here is a Baker's cyst, a localized collection of fluid. Baker's cysts result from an excess of synovial fluid within the knee joint capsule, which leads to a ballooning at its weakest point. This happens to be posteriorly. You should always try and identify the root cause of this excess fluid, however, and not consider a Baker's cyst as a definitive diagnosis in itself. Still posteriorly, inspect the calves. Observation of muscle atrophy may be aided by getting the subject to perform a calf raise. Although it can sometimes be quite obvious, as here on the left. Alternatively, you may also observe calf swelling, which in this case is secondary to a ruptured Baker's cyst. It could also easily be caused by a deep vein thrombosis. Then inspect the ankles for alignment. You may observe a rear foot varus, or more commonly, a rear foot valgus. If you observe a rear foot valgus, ask the patient to heel raise and see if it reduces under the action of tibialis posterior. If it doesn't, then impaired muscle function is suggested. Now is a good time to examine gait. While gait analysis can seem complicated, there's only a handful of gait anomalies commonly seen which directly relate to knee pathology. Firstly, not specific to the knee, is whether or not the patient is limping, which is called an antalgic gait. Basically, if weight bearing on your leg hurts, you're going to spend as little time as possible on it. This also impacts step length on the contralateral side, which is necessarily shorter when swing time is reduced. The knee usually flexes twice during the gait cycle. The first in the stance phase, which begins at heel strike, and basically serves as a shock absorption function. The second knee flexion is much larger and allows the foot to clear the ground during swing phase. This begins at toe off. While loss of knee flexion in swing phase is obvious, loss of flexion in stance phase is much more common, and while it can be difficult to define the degree of knee flexion during stance, its absence is very obvious. Here you can see the subject is basically walking on a stilt during stance. This pattern of gait is often seen in conjunction with deficiency of quadriceps activation, secondary to either weakness or pain inhibition. If the range of internal rotation from neutral is less than 20 or 30 degrees, or there's an obvious difference between sides, further hip examination should be performed. Next, assess the patella during extension, looking for excessive lateral motion. This is known as the J sign and is thought to represent maltracking of the patella. Now, ask the patient to extend the knee while palpating the patella for crepitus. This can indicate osteoarthritis involving the patellofemoral joint. Quadricep function and extension range can now be assessed. Have the patient actively extend their knee and then passively extend it. Look for any evidence of a quads lag where the passive range of extension is greater than the active range. Palpate the anterior thigh for quadriceps activity and assess strength by applying resistance at the ankle. An assessment of hamstring strength can also be conducted in sitting. We now move the patient into supine. This is a good time to perform a functional assessment of leg length using the Weber-Barstow manoeuvre. First, the patient bridges to square up the pelvis, and then their knees are extended. The heights of their medial malleoli are then compared, a difference of more than 1.5 centimetres being considered significant. We then inspect the knee again, paying close attention to scars and swelling. Be sure to inspect the gutters either side of the patella, which can help you identify more subtle swellings. This occurs where excess bursal fluid has altered the normal contour of the knee. Even if swelling is not visible, temperature changes about the knee can indicate inflammatory pathology. Using the back of your hand, feel the skin above, at the front of, and below the knee. Normally the front of the knee is noticeably cooler than the thigh above and the leg below, so that as you feel from the top down, you should get a warm, cold, warm pattern. In an inflamed knee, however, this pattern may be markedly attenuated, or even reversed. Next, we perform physical tests for effusion. Understand that in most people, about 85%, the large suprapatellar bursa communicates with the knee and may therefore accumulate fluid during a knee injury. The milk or sweep test is based on the premise that you can move fluid from one side of this bursa to the other and back again. Firstly, sweep your hand alongside the medial aspect of the patella, coming around the top. This aims to move any excess fluid from the medial gutter. While observing the medial gutter, sweep your hand down the lateral aspect of the patella, which can move the fluid back. This is an example of a positive sweep or milk test. Another test for the presence of an effusion is a patella tap or ballottement test. This test is based on the premise that compression of the superior aspect of a distended suprapatellar bursa will shift the fluid beneath the kneecap and lift it into the air. Essentially, the patella will be floating on a cushion of fluid. Downward pressure on the patella can then cause the patella to descend through this fluid and tap the femur, which can often be felt. Now is a good time to assess the range of knee flexion. Some clinicians may choose to leave assessment of extension range and strength until now, rather than doing it in sitting as we did earlier, and that's very reasonable. We then come to palpation, which begins with the knee extended. We recommend beginning palpation above the patella, moving inferiorly, and then repeating both medially and laterally. Begin in the distal quadriceps, coming first onto the quadriceps tendon and then the patella. At this stage, patellar mobility can be assessed, more than 2 quadrants mobility suggesting hypermobility. The medial and lateral articular facets on the underside of the patella can then be palpated. Continue on to the patella tendon, palpating it along its length from the inferior pole of the patella to the tibial tubercle. Elevating the inferior pole of the patella by pressing down superiorly may allow you to palpate the deeper fibres of the patella tendon. Beneath the inferior patella and the patella tendon is the infrapatellar fat pad. This can be directly palpated on either side of the patella tendon and indirectly compressed by the inferior pole of the patella. Palpation then proceeds on either side of the patella. Pay particular attention to a shelf of tissue often felt as a small cord on the medial aspect of the patella. This is called the medial plica. This is an underdiagnosed source of pain occurring in deep knee flexion and is difficult to see on imaging. Also medial to the patella is the medial patellofemoral ligament, which is a key stabilizer preventing lateral patellar dislocation. It can be palpated along its length for tenderness from the medial border of the patella to around the medial femoral epicondyle. Palpation then continues with the knee flexed to 90 degrees, focusing on the medial and lateral joint lines. Find the soft indentation medial to the patella tendon and identify the medial femoral condyle superiorly and the tibial plateau inferiorly. Follow the joint line around medially until you lose the joint line. When this occurs, you'll be over the medial collateral ligament. Take this opportunity to palpate along the length of the ligament from the medial epicondyle to the medial aspect of the proximal tibia. Now is a good time to palpate the pes anserinus, the site of insertion of 3 conjoined tendons and a common site of tenderness. One of these tendons, semitendinosus, is the most prominent tendon over the medial aspect of the posterior knee. After finding it in the thigh, follow it forward to the knee until it becomes less distinct. Now ask the patient to alternately isometrically contract and relax their hamstrings, allowing you to follow the semitendinosus tendon to its insertion site. This is the site of the pes anserinus. We now move to the lateral joint line. Start by finding the soft indentation immediately lateral to the patellar tendon as you did medially. Follow the joint line around. On the lateral aspect of the knee, you'll be over the lateral collateral ligament. This can usually be palpated as a taut cord by dropping the knee out laterally and applying a varus force to the knee. Once you've found the LCL, palpate it along its length, feeling for its origin over the lateral epicondyle of the femur and its insertion into the head of the fibula. The head of the fibula is an important landmark for the common peroneal nerve that wraps around it. The common peroneal nerve is often readily palpable across the posterior aspect of the fibular neck in slim subjects. The head of the fibula is also the site of attachment for several tendons and ligaments. This includes the tendon of the biceps femoris muscle, which is readily palpable as the most prominent tendon over the lateral aspect of the posterior knee and can be followed to its insertion onto the head of the fibula. Irritability and stability of the proximal tibiofibular joint can be readily assessed by grasping it between the index finger and thumb and attempting to mobilize it. From the head of the fibula, move anteriorly to the prominence over the anterolateral proximal tibia, known as Gerdy's tubercle. This is the site of attachment of the iliotibial band, which can be felt as a thickened band within the lateral thigh. Inserting behind Gerdy's tubercle is the anterolateral ligament, which is important for rotary stability of the knee. Avulsion of the anterolateral ligament is responsible for the Sagon fracture, which can occur with ACL rupture. It can be palpated up to its origin on the lateral epicondyle of the femur. The next phase of our examination is ligament testing, beginning with the collateral ligaments. The medial and lateral ligaments of the knee serve to restrict valgus and varus forces respectively. The joint capsule provides some resistance to varus and valgus forces when the knee is extended, and so to isolate the collateral ligaments, examination should be performed with the knee in 15 to 30 degrees of flexion. The lateral collateral ligament is best assessed by dropping the leg over the edge of the bed to stabilize it before applying a varus force through the ankle. To test the medial collateral ligament, support the calf and apply a valgus force to the knee. You can also palpate the medial joint line with your fingers to feel for any gapping, which will help you grade the injury. The cruciate ligaments are examined next. Looking at the orientation of the posterior cruciate ligament, you can see it restricts posterior movement of the tibia on the femur. Hence, disruption of the posterior cruciate ligament can lead to the tibia moving backwards relative to the femur, or sagging. This is known as the posterior sag sign. This is best assessed with the knees flexed to 90 degrees while looking from the side. A posterior sag may also be evident with the quad slag test, where the patient contracts their quadriceps with their foot secured. The pull of the quadriceps can bring a sagged tibia forwards. The anterior and posterior draw tests are best performed as follows. Sitting on the patient's foot, wrap your fingers around the proximal calves, the lateral borders of your index fingers contacting the medial and lateral hamstring tendons, while your thumbs span the anterior joint line either side of the patellar tendon. This allows you to both feel for spasm in the hamstrings with your fingers, while feeling the relative movement between the femur and tibia with your thumbs, while you apply an alternating anteriorly and posteriorly directed force. The correct interpretation of increased anterior tibial translation with the draw test requires knowledge of the starting position, that is, a sagged or neutral position. If you're starting from a sagged position, then increased anterior translation simply confirms a deficient posterior cruciate ligament. On the other hand, excessive anterior translation from a neutral position suggests deficiency of the anterior cruciate ligament. If you suspect a disrupted ACL, you should also perform the Lockman's test. The Lockman's test is based on the premise that by first relaxing the anterior cruciate ligament, a sudden but controlled anterior translation can jerk it taut, which can be felt as a firm endpoint if the anterior cruciate is intact. A torn anterior cruciate will result in an indistinct or soft end feel. The Lockman is usually performed with the knee in 15 to 30 degrees of flexion. It's often easiest to stabilise the patient's leg by putting your knee under their distal thigh. Then gripping the proximal tibia, apply a smooth anterior force. If the ACL is intact, you should detect a firm endpoint. You may also stabilise the patient's thighs with your hand, though this can be difficult with larger patients. If you're having difficulty, experiment with varying degrees of knee flexion. Often the clearest endpoint will be found with only slight knee flexion. Also pay attention to the direction you're applying force. It's not uncommon for beginners to direct their force too laterally, especially if they're short and have trouble getting over the top of the knee. One strategy is to gently externally rotate the thigh to help align the sagittal plane of the knee with the force being applied. We now come to the McMurray's test, which aims to assess for meniscal pathology. First, identify the medial and lateral aspects of the anterior joint line and place your index finger and thumb over it so you can feel for any clicks or clunks. Next, grasp the heel with your other hand and fully flex the knee. Now internally and externally rotate the tibia via the heel while extending the knee. A positive test is a palpable clunk. Another special test is the Moving Patella Apprehension test. This modified version tends to be more comfortable for the patient. Begin with the patient's knee in about 30 degrees flexion and fully supported by your thigh. At this point, the patella is nestled between the femoral condyles, providing some stability against lateral displacement. Then apply a laterally directed force to the patella. If the patient does not experience any apprehension, passively extend the knee while maintaining the laterally directed force. Then repeat the same process with a medially directed force. Apprehension or contraction of the quadriceps present with a lateral force that is absent with a medially directed force is considered a positive test. We now position the patient in prone, inspecting for hamstring or calf wasting and palpating for a Baker's cyst. Next up is the dial test. This assesses the integrity of both isolated posterolateral corner structures and the posterior cruciate ligament. Injury of each can result in increased tibial external rotation at different degrees of knee flexion. The patient's knees are first brought together and then flexed to 30 degrees. The ankles are then externally rotated, comparing the range between sides. An increase of more than about 10 degrees on one side, while at 30 degrees flexion, is thought to be indicative of an isolated injury to posterolateral corner structures. The knees are then flexed to 90 degrees and the external rotation repeated. Excessive tibial external rotation here is thought to represent an isolated posterior cruciate ligament injury. Excess tibial external rotation at both 30 and 90 degrees suggests a combined injury of both structures. The next test we come to for the anterior cruciate is a pivot shift, designed to assess for the rotary instability that often accompanies anterior cruciate injuries. The reason we don't include this with the other anterior cruciate tests is that it can be quite provocative, so it's usually best left to last. The basis of the pivot shift test is that in an ACL deficient knee, internal rotation of the ankle can anteriorly sublux the lateral aspect of the tibia relative to the femur. And so, with the knee in extension and maintaining internal rotation of the tibia, a valgus force is applied to the lateral knee. The knee is then flexed. This flexion may reduce a sublux tibia, which may be felt by both patient and clinician. A positive pivot shift test ranges from the sensation of the tibia gliding back into place to an audible clunk. It can be useful to palpate the lateral joint line to better appreciate movement between the femur and tibia. The mechanism of reduction is based on the direction of pull of the iliotibial band, which changes as the knee flexes. In a flexed knee, the iliotibial band is able to pull the tibia posteriorly back into place. It's worth noting that an intact medial collateral ligament is required both to act as a pivot point for the lateral subluxation of the tibia and also as a tensile brace to generate lateral joint compressive forces. Without an intact medial collateral ligament, the pivot shift test cannot be performed. If you're having trouble with the handling of the pivot shift test, an alternate technique that many beginners find much more natural is to cradle the ankle in your elbow, resting that hand on the inside of your other forearm. Your free hand can then rest on the lateral aspect of the proximal leg and internally rotate the tibia while applying a valgus force. Finally, the combined motion of your arms can flex the knee. This is actually much easier than it looks, but it's not quite as sensitive as the traditionally described manoeuvre. The final test is Thessaly's test, looking for meniscal pathology. We regard this test as superior to McMurray's test, but recommend leaving it until later in your examination after you've excluded other significant pathologies such as ligament disruption. To perform Thessaly's test, support the patient in single leg stance and have them flex their knee to about 20 degrees. They then rotate their body in both directions. A positive test is usually indicated by joint line discomfort or a sense of catching. You may also perform Thessaly's test up against a wall. And that's a wrap. Thanks for watching.